Hello, ladies and gentlemen. This will be a talk on dysphagia, a very, very common symptom. So you're going to want to know this one because it's probably one of the most common complaints next to heartburn and indigestion that you'll get as far as the GI system goes. So very high yield for the USMLE. This is part of our surgery talks, but it could just as easily be part of our GI talks. The difference here is we're going to introduce a couple surgical interventions that are done for some of these causes of dysphagia. And there are some unique features for each of them, so you'll want to know what each of those are. It'll help you tease them out when you have a multiple choice question. If you haven't had the opportunity yet, please consider subscribing to my Patreon at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right-hand corner of the screen, and it should link you up. If you consider chipping in $1 a month, little tiny bit goes a long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium content in which I go over case reviews, differential diagnosis, treatment plan, systematic way of going about things that will be useful for you as you go about residency, step 3, and so forth in your clinical practice. So thank you very much in advance for your consideration. So let's start talking about dysphagia. So there are two different types of dysphagia. There is dysphagia to solids only and dysphagia to solids and liquids. So that's something that you're going to want to get in your history. But before we get that history, what is dysphagia? Do I even have it here? No, I don't have it here. Okay, so what is dysphagia? Now, I've encountered a lot of medical students who talk to patients and they have a patient that has pain when they eat, and they call that dysphagia. Is that dysphagia? No. Dysphagia means you have difficulty swallowing, difficulty getting the food from your mouth to your stomach, and maybe that causes you to regurgitate. Maybe it just causes a feeling of fullness in your chest or in your abdominal area. But invariably, they have difficulty swallowing. If you ask them, is it difficult for you to swallow? They'll say yes. Now, if they have pain on swallowing, that's an entirely different animal. That's odynophagia, and that's a different differential. Now, some of these things do cause pain on swallowing. They do cause pain, in particular, as we're going to talk about the diffuse esophageal spasm. But not all of these have pain. So dysphagia is not pain necessarily. It's just difficulty swallowing. Odynophagia is pain with swallowing. All right, so we're going to talk about 5 different things here. They're bold-faced in the yellow font here. Zenker's diverticulum, esophageal stricture, esophageal cancer, Achalasia, and diffuse esophageal spasm. Some of these other things I talk about elsewhere in the general surgery section or in the GI section. Oh, let's start with a vignette. Here we have a 59-year-old man whom you regularly see who presents to your clinic complaining of difficulty swallowing food and vomiting for the past 2 months. He says that the food seems to get caught up in his throat, pointing to his upper neck. Always look for where the patient's pointing. That gives you a good hint. He says sometimes after dinner he vomits, but it, quote, tastes and looks like what I just ate. He is otherwise healthy, active, and has no other medical problems. Physical exam is unremarkable. However, when assessing his dentition, you note halitosis. Remember, part of your GI workup is going to be to look at the mouth. And you often get a good whiff of their breath when you're doing it. So we find 4 very important things here that lend ourselves to a presumptive diagnosis of Zenker's diverticulum. First of all, difficulty swallowing food. Well, that's dysphagia. So now we've got our differential for dysphagia, which you should have in your head. This is in the upper neck, as we're going to see Zenker's diverticulum involves the upper esophagus. He says that he's vomiting. But it's important that you ask the patient, what does the vomit look like? You might even ask them what it tastes like. And he says that it looks like what he just ate. So this is not actually vomiting. Vomiting is the stomach contents coming up. This is actually regurgitation. This is just the food that was in the esophagus and then comes back up. So that's regurgitation. So this is different from vomiting. And then you also note halitosis. So these are all symptoms consistent with a Zenker's diverticulum. My experience on the USMLE has been that, and looking at MBME questions and even the internal medicine board examination, the ABIM, is that the Zenker's diverticuli come up pretty stereotypically. So if you know this stuff, you'll be good for the test. So the Zenker's diverticulum is a false esophageal diverticulum. What happens is the esophagus gets herniated through a weak part of the cricopharyngeal muscle in the neck. So there's a weak part of that muscle, and the pressure of the esophagus exceeds the pressure outside that weak portion, and so the esophagus pouches through, and that causes a diverticulum. And so we call this a Zenker's diverticulum, and it's always at the level of the cricopharyngeal muscle. The classic presentation is dysphagia with regurgitation of undigested food. Because of what's happening is in that pouch, you get food, and of course there's bacteria, and that food begins to rot, and that's what causes the dysphagia. You're not going to note any problems with dentition because they're not vomiting. So if they were vomiting frequently, you might notice problems with the enamel. But they're not vomiting. They're just regurgitating food contents, and there's no acidity there. So the teeth will be normal, but the breath is going to be really foul. History: typically the patient is older, and that comes with weakness of a lot of muscles, and the cricopharyngeal included. In some cases, there may be aspiration pneumonia. That's just because of the constant regurgitation. Remember, aspiration pneumonia does not have to come from vomit. It can come from any kind of content that comes from the GI tract or otherwise. Anything that you aspirate into your lungs, it can result in a pneumonia. Symptoms include dysphagia, regurgitation, sensation of fullness in the neck. That's very important. There are sensory nerves around that area, so they can feel that fullness. They'll point to their neck. Halitosis, as mentioned, and the patient is sometimes able to manipulate their neck and regurgitate the food on their own. So you might want to look for that too. The diagnosis, the best initial diagnostic step is going to be a barium esophagram. Very easy test to do. You have them swallow some really nasty tasting barium solution, and then you take an x-ray and you see the outpouching, and that's typically good enough diagnostically. However, the most accurate test is it would be let me just leave it at that. Barium esophagram is going to be the only thing that you'll be asked to answer on the USMLE. I'm not even going to go any further than that and confuse you. So barium esophagram is diagnostic for Zenker's diverticulum. The treatment is a cricopharyngeal myotomy. This is a surgical treatment because we need to repair this diverticulum. And usually you'll then resect the diverticulum and staple it. So this does require surgery. So here's what a Zenker's diverticulum looks like. You can see that they're swallowing, and there's barium down the esophagus. Here's your pouch right here. And then once that barium goes down into the stomach, you can see there's still some residual barium in the pouch, and this is why this is the same reason why food gets stuck in there. So this is our treatment, the cricopharyngeal myotomy. What you do is you make an incision into the cricopharyngeal muscle, which will then reduce the herniation, equalizing the pressure. The herniated portion is typically removed because it's not really going to be functional at that point. So you'll remove and staple that portion. There are some complications, of course, perforation of the esophagus. If you don't close it all the way, then you can get problems from that. And then, of course, there are nerves in that area, so you can get recurrent laryngeal nerve paresis. Remember, the recurrent laryngeal nerve travels along in the vicinity of the esophagus, and so, of course, that would cause voice hoarseness because that does innervate the vocal cords. Okay, let's do another vignette. We have a 59-year-old man who presents to your clinic complaining of difficulty swallowing food, which has been getting worse over the past several months. He says that the food seems to get caught up in his throat. He also says that he has heartburn from time to time, for which he takes Tums, which is calcium carbonate. His medical history includes type 2 diabetes, which is controlled on metformin. His BMI is 29.3, unchanged from 6 months ago when he was last in for his A1C levels. Physical exam is unremarkable. All right. So this is characteristic of an esophageal sphincter. We have an otherwise normal appearing, healthy patient who just says that it's difficult to swallow and the food feels like it's getting caught. Now, is this presentation diagnostic for an esophageal stricture? Absolutely not. We're going to need to get testing. But this is very characteristic of esophageal stricturing. A history of GERD can predispose you to esophageal stricture, so that history of heartburn may be behind this, but you don't have to have a history of GERD to get an esophageal stricture. It has slowly been getting worse, and so these do tend to progress. But remember, keep in mind that they do have dysphagia. That is at the root of these presentations. Okay, do note also that his BMI has not changed, so he doesn't have weight loss. This can also look like a cancer because really a cancer is a physical obstruction of the esophagus, so it can cause very similar symptoms, but typically with progressed esophageal cancer, there will be weight loss. So his BMI is unchanged, so that's good. So esophageal stricture is simply a narrowing of the esophageal lumen. It's a mechanical obstruction. Numerous possible causes. Most commonly, it's due to GERD in about 80% of cases. Other causes include autoimmune processes, pill-induced damage, which would result in inflammation, and then proliferative overgrowth of the surrounding esophagus, acute caustic injury along the same lines, malignancy, and more. This is a progressive presentation. It starts with an insidious dysphagia, especially when caused by GERD. There may or may not be an established history of GERD. Sometimes there's hoarseness or poor dentition. And then weight loss can be a cause, or it can be a presentation with a lot of these. It's really nonspecific. So like a really fast weight loss points us towards cancer. But just a general progressive slow weight loss, that could be with any dysphagia because they're not eating as much, because it's not comfortable, so they just don't eat as much, and that causes them to lose some weight. So you want to make sure you ask them, are you eating as much as normal? Are you not eating because of these symptoms? That's important. Typically patients with any kind of cancer, they eat but they lose weight because they're in a state of cachexia. Diagnosis, the best initial diagnostic step is going to be a barium esophagram. You should see the stricture quite nicely. Treatment is esophageal dilation, which is performed endoscopically. So here's the stricture. You can see a nice confluent stricture here. And the treatment is esophageal dilation. You don't need to worry about how to do that. Just know that that's the treatment for stricture. Okay, we have another vignette. Nope, we have the same guy coming in, but just different symptoms. A 59-year-old man presents to your clinic complaining of difficulty swallowing food, which has been getting worse over the past couple months. He says that the food seems to, quote-unquote, get caught up in his throat. His medical history includes GERD, which has been an ongoing issue for the past 25 years. You note that he's lost 15 pounds since his last visit a month ago for back pain. He says that he hasn't been trying to lose weight. Physical exam reveals mild cervical and left supraclavicular lymphadenopathy. All right, so again, another patient coming in with dysphagia. You always want to get a good GI history in that case. We got GERD here. It's been an ongoing issue, and then the really important alarm symptom of unintended weight loss. And anytime you got a patient with unintended weight loss, you better be checking lymph nodes all over the place. And of course, the first place you're going to go is the cervical lymph nodes and the supraclavicular lymph nodes. Those are the most commonly palpated lymph nodes. And you will note lymphadenopathy in these patients. There should be swollen lymph nodes, especially if this is a more progressed cancer, and typically it is in order to cause that weight loss. So look for that on the test. So esophageal cancer comes in two flavors: adenocarcinoma, which is associated with a history of reflux disease, and then there's also the squamous cell carcinoma, which is associated with a history of smoking and alcohol use. It tends to be that adenocarcinoma has a higher predilection in whites, whereas squamous cell carcinoma has a higher predilection in blacks, but that's really not very reliable. But look for if they have a long-standing history of GERD, it's likely an adenocarcinoma. If they don't, but they have more smoking and alcohol use, heavy alcohol use, it's probably a squamous cell carcinoma. But the only way that we can tell is through biopsy. Symptoms for esophageal cancer include progressive dysphagia, which may progress to include liquids. Unintentional weight loss, like any cancer. Upper GI bleeding can eventually occur as these cancers begin to necrose. Epigastric pain, bone pain, lymphadenopathy, we're getting here towards your general cancer symptoms. And of course, GERD symptoms, because that's often behind their cancer. Remember that GERD leads to the Barrett's esophagus, and then the Barrett's esophagus eventually that's a premalignant condition, eventually will turn into an adenocarcinoma. Diagnosis: the best initial diagnostic test when suspecting esophageal cancer is a barium esophagram. And that's to aid the endoscopist, if that's a word. So the gastroenterologist is going to want to know roughly where this tumor is so that they know where to look. And a lot of times that's helpful for them mechanically, so they don't, so they can be a little bit more careful because this tissue can be very friable and it can cause bleeding. So they'll want to know where it is so they can be careful once they get to that area. So you probably notice a pattern. Barium esophagram is a really good test to do for dysphagia. It's a really good first step. In many cases, though, we will need to go on to do endoscopy, either to get a biopsy or get a good look, or, as we're going to see, to do manometry with some of these other problems. EGD and biopsy will be needed thereafter. So obviously, you need to get the biopsy in order to make a definitive diagnosis of cancer. The treatment depends on staging. Esophagectomy is really the only hope for a cure, but most patients, unfortunately, are not candidates. So here is an EGD. This is done in consort with a biopsy, and this is the cancer right here. So the treatment is either esophagectomy or palliative care. Esophagectomy is the only way you can cure it. So if the patient is a candidate, you can do it. You don't need to worry about how to determine whether the patient is a candidate. Typically, cervical or supraclavicular lymphadenopathy will exclude surgery as well as other metastases. So typically that's going to rule them out for esophagectomy. Esophagectomy really can only be done if the cancer is restricted to the esophagus. Palliative care is probably what the test is going to ask you about. And this is done to reduce symptoms. However, this is a terminal condition. Medically, you can give them 5-fluorouracil, which I believe does reduce the tumor bulk and will help with the symptoms. Surgically, you can do esophageal dilation, very similar to how you would go about managing an esophageal stricture. Really, it's kind of the same thing. You got a mechanical obstruction of the esophagus. So let's do another vignette. We have a 43-year-old woman presenting to your clinic complaining of difficulty swallowing food and liquids. Very important there, food and liquids, which has been going on for the past 2 months or so. She denies significant pain, but she says that there's a feeling of fullness and pressure in her chest when she eats. She says that her symptoms seem to have been getting worse. She does not smoke or drink alcohol and has no significant chronic illnesses. Her weight has been stable. So, of course, we've got a woman with dysphagia here, but what are the associated symptoms? Well, a fullness and pressure. And what does fullness and pressure signify? Well, in consort with dysphagia, it signifies that there is something not getting down properly. So food or water or fluids are getting stuck. And that's what's causing the sensation of pressure. And this is very common with achalasia. So achalasia is where the lower esophageal sphincter that separates the esophagus from the stomach does not relax properly. And so food cannot get from the esophagus into the stomach. And so it just kind of goes down via peristalsis and gravity and gets stuck down there. And that causes the pressure. Our esophagus is not meant to be a stomach. But that's essentially how it's acting when you keep swallowing and you fill up the bottom of your esophagus, and that's ultimately going to cause pressure and a sensation of fullness. Note that her weight has been stable. However, if her achalasia has been going on long enough and she's not eating as much, you might notice a weight loss. So the weight loss, you really just have to make sure you ask the patient, have you been eating as much as normal? And if they have been, then we get worried. If they haven't, well, then that's probably the explanation. So as I said, achalasia is the failure of the lower esophageal sphincter to relax properly, which results in an inability of food and liquids to enter the stomach. Symptoms include dysphagia to both solids and liquids, regurgitation, which would happen similar to a Zenker's diverticulum, but this will never be rotted food because the food typically just doesn't stay down there that long. The symptoms may worsen at night. Notably, they will not have any heartburn, and like I said, they could have weight loss, but it's due to not eating as much. Diagnosis, the best initial diagnostic test when suspecting achalasia is a barium esophagram. It gives us a very characteristic bird's beak pattern. However, this is not necessarily a very sensitive test. You might not see the bird's beak. And so for that reason, we should follow up a barium esophagram with an esophageal manometry, and that is the most accurate test. And I'm going to show you how to read an esophageal manometry. You do need to know the basics for the USMLE. The treatment for achalasia is something called a Heller myotomy, and what you're basically doing there is, to put it crudely, you're cutting the lower esophageal sphincter and making it more, not submissive, but a little more docile. It'll relax easier. A lot of times surgeons will, when they do the Heller, what they'll also do is a partial fundoplication, because what we found is that by doing the Heller, it actually causes the lower esophageal sphincter to relax too much. And that is going to, of course, result in reflux disease. So we kind of balance that out with a Nissen fundoplication, and that will kind of bring sort of a good balance. So a lot of times you'll see Heller done with fundoplication. Remember, fundoplication is done for surgical treatment for refractory reflux disease. Patients who aren't surgical candidates can get Botox injections to the lower esophageal sphincter. So consider that as well, especially for your older patients. So this is a normal esophageal manometry here. Probes are placed, well, they're not placed, but they exist on the scope, and they sense the pressure in the esophagus. And what you have the patient do is swallow, and then you'll notice this peristalsis. As the peristalsis wave goes down, you see a progressive, this is over the course of time here, pressure over time on your x-axis. And you notice the peristalsis, the increase in pressure. And what you always should have is, at some point, the lower esophageal sphincter should relax, and it should go down roughly to 0. Now, what you're going to see when you have achalasia is the lower esophageal sphincter never gets down there. It's constantly, even when it's supposed to be relaxed, it's constantly in some state of contraction. And so you never really, your lower esophageal sphincter never really gets down down to 0. And so you've got really a tonically contracted lower esophageal sphincter. Okay, so failure of the lower esophageal sphincter to relax. So you see it again here. All right. So this is what the barium esophagram looks like. You see you have the bird's beak, and this is just accumulation of the barium fluid, but it does not get into the stomach. Some of it will trickle in, but you just see you have a major accumulation here in just this narrow little area here. This is where the sphincter is. So normally what should happen is all of this should flow in a lot faster, but because the sphincter is not relaxing, it's just trickling in very slowly. As I said, the treatment is a Heller myotomy. It's the best treatment for achalasia. It can be done laparoscopically. The muscles of the lower esophageal sphincter is cut, and that allows relaxation of the sphincter. Usually this is done in consort with a partial fundoplication to prevent reflux. Okay, we have another vignette here. A 43-year-old woman presents to your clinic complaining of intermittent chest pain over the past couple months. She notes that usually it comes on when drinking her morning coffee. Recently, she was seen for similar symptoms in the ER. EKG and labs, including cardiac enzymes and a lipid profile, were ordered. All were normal. This was done, followed up by a cardiac stress test, which was also normal. She is otherwise in excellent health, and her weight is stable. So what is this patient's complaint? Is it dysphagia? Well, it's not her chief complaint. Her chief complaint is chest pain. So chest pain is, we always worry about heart problems. And absolutely, when a patient comes in complaining of acute chest pain, you need to get cardiac enzymes, EKG, the whole 9 yards. However, once you've ruled out cardiac causes of chest pain, what you need to do is start thinking of GI causes. And one of the most common causes of quote-unquote chest pain is reflux disease. But another cause is esophageal spasm. So if the patient complains of heartburn, a burning sensation that goes up the esophagus, and it's that burning sensation, that's probably reflux disease. But when they refer to it as really just severe pain, that is consistent with a diffuse esophageal spasm. Now, what you want to know is, what are they doing when it comes on? Are they drinking anything? Are they eating anything? Typically with diffuse esophageal spasm, they'll be eating or drinking something, and a lot of times it's hot or cold beverages, or it could be carbonated beverages. That's very common. So typically this comes on when she's drinking her morning coffee. So look for that in the history. And then obviously you want to make sure, especially if you're taking step 3, even if it looks like diffuse esophageal spasm, if a patient's coming in with chest pain, the number one thing you're always going to do is a cardiac workup. So just make sure that that's been done. So diffuse esophageal spasm is uncoordinated esophageal peristalsis. Can you really even consider it peristalsis at that point? No, not really. This is just uncoordinated esophageal spasming. The esophagus just is not contracting the way it should. It's disordered. Usually this presents as chest pain. It is idiopathic. There seems to be a higher incidence in whites and in women, and there's an increase in incidence with age, but it is pretty rare, 1 in 100,000. Symptoms include retrosternal chest pain, dysphagia both to solids and liquids, and there may be some regurgitation, but that's not very common. Often it's triggered by hot or cold foods or liquids, sometimes by carbonated beverages, and sometimes it can be associated with stress. Diagnosis: all patients with chest pain should be worked up for cardiac cause. After that, what you want to do if you suspect diffuse esophageal spasm is to get an esophageal manometry. A barium esophagram can be useful, so you can do that. I don't think you'll be asked to do one or the other, but manometry is just better. The reason is that you're going to get a lot of false negatives with the barium esophagram. That corkscrew appearance, if you have it, it's diagnostic, right? Because you don't see the corkscrew appearance with anything else. But in most patients, you're not going to find that. They need to actually be actively having a diffuse esophageal spasm in order to notice the corkscrew appearance. So esophageal manometry is really the best initial test. But if you are given a picture of a barium esophagram, you should know what this corkscrew appearance looks like, and I'll show you a picture of that in a little bit. The initial treatment is with calcium channel blocker. So this is medical treatment first. And you give diltiazem, any calcium channel blocker, but this is the one that I found recommended. But you won't be asked to choose between calcium channel blockers. Myotomy is performed in patients who do not respond to medical treatment, but you should know diffuse esophageal spasm, the treatment is calcium channel blockers. So this is a diffuse esophageal spasm manometry. So notice here, we don't really have any coordinated peristalsis. So normally you would see these peaks occurring one after the next. They should move with time, and you don't have that here. So lack of coordinated peristalsis. This is another good one. So here we only have 3 probes: proximal, middle, and distal esophagus. But again, you see no discernible peristalsis, but you do see fluctuations in the pressure. This is just the definition of spasm. And then this is the corkscrew esophagus. So if you see this, you know your diagnosis, but the problem is it's not always going to be present if you were to perform it, so manometry is just better. This is an illustration of what manometry looks like. Two of the things that we talked about, we didn't talk about scleroderma, but achalasia and diffuse esophageal spasm. If you're given a manometry on the USMLE, it will be one of these two things. So just to review, dysphagia to solids, Zenker's diverticulum, regurgitation, halitosis, they're regurgitating rotten food. This is a diverticulum at the level of the cricopharynx, and you're going to diagnose this with barium esophagram. You'll easily see the diverticulum, and you treat this with cricopharyngotomy. Esophageal stricture, usually history of GERD, which has caused chemical injury and resulted in stricture. This is usually progressive. Again, diagnose it with barium esophagram. Treatment is esophageal dilation, and treat the underlying cause. If it's GERD, make sure that you're treating that. Esophageal cancer, look for weight loss, lymphadenopathy, all your typical cancer signs. Smoking and history of alcoholism, very consistent with a squamous cell carcinoma. Long-standing history of GERD, very consistent with an adenocarcinoma. Diagnosis, barium esophagram. That's not going to make your diagnosis, but it's going to show you where any tumor is, and that's very useful for the gastroenterologist. So that's going to be your first step, and this is going to be followed by a scope and a biopsy to really nail down the definitive diagnosis. Treatment is esophagectomy. That's the only way that you can cure it. However, most patients are not candidates, so you'll treat this palliatively, and you can either give 5-fluorouracil or do dilation. Dysphagia both to solids and liquids is usually going to be a problem with the coordination of peristalsis. So that can be achalasia, which is going to typically present with regurgitation, but general feeling of fullness in the chest, typically no heartburn. Symptoms may or may not worsen at night. The diagnosis, barium esophagram, will show you the bird's beak, followed by esophageal manometry. The treatment for this is a Heller myotomy, usually in consort with a fundoplication. Diffuse esophageal spasm, chest pain, looks like cardiac pain, but it's not. Sometimes they may have a psych history or symptoms. This can be triggered by stress, but also look for food triggers, hot or cold foods or beverages, carbonated beverages, and so forth. After you rule out a cardiac cause, esophageal manometry is really the best way to go. However, if you are given a barium esophagram, look for that corkscrew pattern. The corkscrew esophagram is really just a kind of a buzzword, so you'll want to remember that for diffuse esophageal spasm. The treatment for DES is calcium channel blockers, and then myotomy if that fails. And that is all I've got for you.